And as I said earlier as well, some of the slides that I usually use as an impact slide, maybe we'll spend some time on that because that will give you a little bit of an idea as to what is happening in today's lecture and how are we going to deal with it. Now, this is an important slide. I want you to pay attention. The only thing I can add is this is not the same guy holding the same woman, so that's not a case over here. So there are two different scenarios, and these are some of the, we call it classical slides that actually exist in the history of medicine. And this one on the left, I can just give you a little bit of an upshot for that. It comes from the horror of cholera in Bangladesh in the early 1970s. So that's one comparing with another scene over here. I want you to pay attention to it. And of course, they are patients, and you must have figured out the patient is a female, not male. So there are some classical features that you will see, and that's the whole idea that I want you to pay attention to. Okay, so let's move on. Now, you can see from here, for example, on the left-hand side, I'll start with the face because that's something that you see very obviously on any patient. You can see pallor, see extremely anemic, pale face. That is a typical feature of shock, as if this patient has no blood at all. So absolutely white. And you can see from here a typical picture and kind of drowsy as well. So that's number one thing that you will notice in this patient. The second thing you will notice again will be the position of her fingers over here, like stretched out. And third thing is the back. So you'll see if you compare back of this patient with the other back, so she is basically flexed forward. We call it flexed forward as compared to this one over here, she is flexed backward. So these are some kind of positions that are important when patients present themselves to. Again, you will see over here heels, her heels, again, they are anemic, white, as if there is no blood there. Normally, no matter what color of skin do you have, your palms and heels give a little bit of a tinge of reddish, whether regardless of what skin color you have. So these are like four important things on this one. On the slide on the right hand side, again, you will notice, number one, her face. So you will see contraction of the muscles. So that's like an upshot for that. You see contractions of muscles over here. Then if you look at her neck, and you will see a spasm, we call it laryngospasm, spasm of the larynx. Of course, there are muscles over there. And then again, you can also see her hand. This is kind of flexed inside. So a little bit of like, we call it like a seizure, like a contracture there. And again, if you pay attention to her leg as well, and then the position that she basically is flexed backwards. So her back actually is hyperextended. We call it a hyperextended back. So that is basically a classical case that you saw in a larger picture of the same woman. And this has been preserved as teaching today's bacteria. And this basically, I hope you don't see it in your life, but this is a classical case of tetanus. This is a classical book case of tetanus, and you can see a cartoon. It says over here, a preventable surgical tragedy. We could have prevented it if we had properly vaccinated her. Again, the position I said is called opisthotonus. Opisthotonus, because you are hyperextended in the back, and that's a classical feature of tetanus. Then you see that she was conscious, fully conscious, as compared to the previous one. She looked in shock. Laryngospasm, spasm of the muscles of the larynx, would suggest to you that respiratory problem is a major problem in this case. You see the clenched fist. So clenched fist, I showed you like contracture. like a spasm of the muscle. So that's the key. And then again, of course, that wasn't visible. It was only a minor wound. Only a minor wound, a scratch, a roadside accident, a minor wound. Just a minor wound will give you such a dreadful picture. So that basically is the impact slide for today that I'm going to discuss today in the family of bacteria called Clostridia. And these bacteria are responsible for tetanus. Again, of course, Clostridia tetani isn't responsible for that specific disease, but we have a bunch of other important Clostridia family members. So Clostridia is like a plural. Singular is Clostridium perfringens, tetani, botulinum, and difficile. So let's take them as a whole family, and then we can go back and take them individually so you can start making a kind of a table or a chart that can help you based upon those 5-6 things I told you: physiology and structure, clinical feature, pathogenesis, epidemiology, treatment, control. So these are some of the major themes that Dr. Murray's book has adopted, and I'm going to stick to it for all practical purposes for teaching all microbes. All right. So this particular family of organisms is ubiquitous. This means present everywhere. It's in the soil, it's in the water, it's in the sewage, and on top of that, which is something that you need to remember, we have this one as a normal microbial flora. So this is a human and animal normal microbial flora, and we harbor this particular organism in our intestines. Okay? Classically gram-positive rods. And a good thing is that most of them, other than the culprits that I just mentioned, they are harmless. And some of them are pathogens. Remember the term we discussed earlier. Pathogens are those bacteria that would always cause disease. So these are pathogenic bacteria. And of course, they have been classically associated with a human disease. So that's what we are going to discuss today. Clostridium tetani causes tetanus. Clostridium botulinum causes botulism. Clostridium perfringens cause gas gangrene. The other name for that is myonecrosis, is suggesting to you that the muscle gets necrosed. And then again, both perfringens and difficile are responsible for diarrhea and colitis. And if you remember the lecture from commensal, I told you if you are using antibiotics overzealously, you want to remove the normal flora, and you will allow some of the bacteria like Clostridium difficile to overgrow and cause a typical situation, pseudomembranous colitis, that we will discuss today as well. Okay, now, of course, this bacteria is going to cause infections. And as you saw in those impact pictures, I told you skin and soft tissue infections. But again, botulinum can cause food poisoning. We talked of antibiotic-associated diarrhea, and of course, colitis. These are generally infections caused by this group of bacteria. The other important thing is that you need to remember is that why are they pathogenic? What is special with this bacteria that make them harmful as compared to harmless that we normally have mostly in our system? And this is what pathogenesis means generally. And of course, this bacteria have an ability to survive in soil, water, and they are ubiquitous. They are there. They can stand adverse environmental condition. They form spores. So that's another important thing. Remember, we talked spores, Bacillus anthracis formed spores. As far as their rapid growth is concerned, they are nutritionally enriched, oxygen-deprived environment. So what it suggests to you is that if a tissue is dying, for example, injury or any other wound or tissue death is occurring, the chances are this bacteria will grow over there because this bacteria has an ability to grow without oxygen. So they basically are anaerobes. That's the term we use. Why do they cause? You must have figured out because that woman had just a minor injury on her front of the foot, and then again whole system was involved. So obviously this bacteria will have this capability to release toxins. So these toxins notoriously are histolytic toxins, meaning lysis of tissues. These are enterotoxin, causing damage to enterocytes, which are the intestinal cells, and then neurotoxin, because you saw a muscle spasm, you saw the position of opisthotonous position of her back. So something is happening to the nerves as well. So keep that in mind. So having talked about some of the general feature of the whole family of Clostridia, let's take one by one. I'm going to begin with Clostridium perfringens. And as I said earlier, this is where you need to make your charts and graphs and want to make sure that you know the differences between all these four. Now, biology of that, you can see each one of them has a way of causing damage. So these are like synonyms. When I say pathogenic or virulent, pretty much the same. They have the ability to cause damage. That's what the virulence is. And then, of course, they will cause a disease. The more virulent the bacteria is, the more bad or severe form of disease they would cause. And you can see from here, since they produce toxins and enzyme that lyse blood cells and destroy tissues, so they can cause overwhelming sepsis, massive hemolysis, and then again myonecrosis, which means death of the muscles. They also produce heat-sensitive enterotoxin, and that basically binds to receptors on epithelium. That's why you get a watery diarrhea, and you lose fluids and ions. So this is like a typical for Clostridium perfringens. So of course, food poisoning will be one of that. If you do gram staining of this bacteria, this is from a wound specimen. So you can see these are rectangular shaped rods. And then you can also see some of them appear gram negative as well. That kind of little bit of decolorization that may happen. And that again, gram staining, though it is considered a good stain, but again, sometimes these bacteria will fail to properly kind of get stained because they're also in the dividing phase. So their cell wall is being metabolized or aging. So there are some kind of dynamic changes that may be occurring on the cell wall because the gram staining is based upon cell wall. So what do? We need to culture it. So we need to culture it, and you can see over here we culture on sheep blood agar, and they get a flat colonies, and these are having hemolytic activities, and then again based upon the zone of complete hemolysis. Complete hemolysis is beta hemolysis, if you remember, and that's because of theta toxin that this bacteria has. So we will go for a gram staining, but we want to confirm it by giving a culture media to bacteria so they can grow, and that will also give us an advantage that we can also do drug susceptibility test as well as to which drug are we going to use for this particular case. Okay, now you can see from here a good table. What are the clinical implications of Clostridium perfringens? We have soft tissue infections. We have, again, myonecrosis, gastroenteritis, and necrotizing enteritis. So these are some of the clinical pictures that we normally see, and all of them have something common because of those toxins that they are released, histolytic toxins, and because of their ability to destroy the blood cells by release of this toxin. And remember, as I said the other day, if you were to get this case, so if you want to use antibiotics, that would not suffice for treatment module for this particular case because most of the damage that you see is because of the toxins. So we have to do something to stop toxins. Okay, and again, you also keep in mind that, for example, myonecrosis is a rapid destruction of muscle tissue. This is where we have highest mortality because once the tissues get necrosed and they start dying out, of course, they would lack the blood supply and your antibiotics creams or antibiotics would not reach over there. Okay, this particular myonecrosis has another historical term that you must have heard, especially I think in World War I and II when soldiers were dying and they had wounds and there was no antibiotics. So they would see a typical thing we call gas gangrene. So you can see this begins with a blackish clostridial cellulitis, and you can see that this can occur by picking up Clostridia from the environment, but also keep in mind they want to make sure that when they operate on you, the surgical instruments they use are spore-free. As I said earlier as well, the scrubs that you're wearing, they are full of spores. They will never ever allow you to walk into the patient room or surgical room with the scrubs that you are using as as a uniform. So this is important because it may occur that a person in this case had a compound fracture of tibia, and then when they did surgery on that, they found out that the instruments were not properly autoclaved. And then again, it caused patient a very severe form of clostridial cellulitis, and you can see necrosis because if there is a lack of blood supply, the tissue will die. And then again, when the tissue will die, there's no blood supply, no oxygen supply, so bacteria will survive. Okay? And as I said earlier, especially the dreadful scenes that they used to see for the soldiers in war before the advent of antibiotics is a gas gangrene. So you can see from here, clostridial infection, and then again tissue starts dying, and you will wonder, why did they open it up? Why do you think they open up the wound? Correct. The thing is because they know that this bacteria is going to divide in lack of air, so you want to open it up to let the oxygen go, so at least they can use that as a way to stop the growth of bacteria. So that was bad, but that's what they used to do. Sorry? Well, when you're talking about the World War I and II, we're talking about the soldiers in the war zone. There's no antibiotic, no care. So the poor fellows are prone to all these kind of injuries. But of course, today we know that we all get tetanus toxide. So we have the vaccination that should care for it. So epidemiology, as I said, present everywhere. Most of the time, they are type A strains. They're responsible for most infection. And then again, wound care. So if you talk of wound care, if you create an artificial wound in surgery, you have to make sure when you open up a patient, you yourself and the instruments and the linen and so on and so forth should not be contaminated with this bacteria. This can also occur when you, for example, take a meat product that was held at temperature below 60 degrees, because remember, these are also temperature sensitive as well. So you have to really give a proper temperature. And if there is an old rotten kind of a food and you happen to eat it, you have a problem of food poisoning as well, because this will go and stick to your intestinal epithelial cell and then cause watery diarrhea. And sometimes they also cause extensive diarrhea in terms of damage and bloody diarrhea. How do you diagnose? Again, classical, this is going to be repetitive for everything I want to talk about. Always will begin with gram staining. We always will have a culture. So these are like gold standards, or some of the immunological tests that we normally do. How do you treat, prevent, and control? Of course, you can see rapid treatment is required. If you have a wound, you need to have a surgical debridement. This is cutting and removing that tissue. That's what they call surgical debridement. And you have to give high dose of penicillin. So IV, very high dose. And then again, you have to give symptomatic treatment of food poisoning. As I said earlier, proper wound care remains as a gold standard for Clostridium perfringens infections. Clostridia tetani is a classical microorganism that happens to be very oxygen sensitive. Remember I said the other day, when people used to have tetanus, they used to put them in oxygen chambers. You used to put them in oxygen chambers as a way to treat them. So oxygen was a killer for this bacteria, like an antibiotic. So what is it that this particular bacteria release? They release a toxin which is called tetanospasmin, as the name suggests, easier to remember, that is going to cause tetanus and is going to cause spastic kind of paralysis. So you have muscle spasm. So that's what you need to remember from this word, very commonly asked question. It is a heat led by a neurotoxin. It blocks release of neurotransmitters for inhibitory synapses. So it basically blocks GABA. So you remember your autonomic nervous system, and basically you know that GABA and glycine are the inhibitory neurotransmitters. So if it blocks that, so contraction phase will be enlarged. Okay. As far as diseases is concerned, again, it's going to cause generalized tetanus, where people will have generalized muscle contraction, and a very severe form of that will cause problems with the cardiac muscles, because cardiac muscle, if they start randomly contracting, you may have arrhythmias, and then again, you'll have all sorts of problems because of the involvement of cardiac tissue in terms of fluctuation in blood pressure and so on and so forth. Sometimes if there is no generalized kind of a tetanus, you may have a localized tetanus. And this is a muscular spasm restricted to the particular area where the primary infection was. And then again, neonatal tetanus, again, is very important because many a time, if the babies are delivered in a non-sterile way and the scissors to cut umbilical cord has spores and you cut it with that, so these bacteria will be passed on to neonates, and that basically is coming from the infected umbilical stump. It has a very high mortality and one of the common causes of neonatal infections. So like Clostridium perfringens, it is again present everywhere. All of us have it as a normal flora. That also will keep you in mind why they emphasize, the hand washing after visiting toilet or washrooms, because the chances are if it's in human excreta, and if accidentally that can be transferred to all these things which are there in those places, you may acquire it. Spore formation is again common, and especially in developing countries because people may have a poor access to vaccine medical care. We expect that most of the countries of the world, well, there's a good expectation, but many times there are countries where there's a higher incidence because they didn't have the vaccination as a childhood vaccination. The other important thing is that many times diseases induce protective immunity. So your body remembers that, it makes a memory T cell, it makes long-lived protective antibodies, but unfortunately this does not. So that's another thing that is important. So in developing countries, people may have roadside accident, people may have other kind of inoculation in terms of acquiring this bacteria, but in Western countries recently, people are suddenly become fond of piercing. So that's another thing, that if you're going to go for piercing, that may inoculate you. And I don't want to talk about what organs people want to be pierced with, but there are quite a few pictures, and I'm going to show some of the nasty ones. that people want to go, they call extreme piercing. So you can see, let alone the piercing which you may have seen in public, there are people, crazy people out there. Okay, anyway, piercing recently of soft tissues and soft part of your bodies have increased the incidence of the problems that we are seeing in young teenagers, let alone these cults. Don't worry about that. So in that picture, you saw a typical contraction of the facial muscles. This is a classical book picture we call risus sardonicus, like a sardonic smile. It means the patient is smiling, but patient is near to his death. And you can see a facial spasm in a patient with tetanus. I'm sorry? No, it is a spastic. It's going to come strong, all of it, at one time. Okay? But what may happen is that when I was being trained in medicine, I remember I saw that. I cannot forget that. But I'll show you what I saw. It's more or less this picture that I saw. So what I saw was, this is like a young boy. And then again, if you see him in the bed, his whole body is wriggling with contraction. Whole body. I mean, you can basically hear the cracking of the, what you call, bones. And that was very devastating, because you can't even approach and touch the patient, because even if you want to look for an IV, you have to look for it. And this spasm is so severe that if you look at the history of medicine, they have shown, and there are pictures like this one, where people's back have broken into two. So you can imagine that kind of a toxin that is released. If the stronger the person is, the more powerful the muscle spasm is. So they can actually break the person's back into two. So that is very horrible. And many a times what they do, which we did for that young boy, when we saw that, we really have to make ourselves basically anesthetize. We wanted to anesthetize the patient, give him, intubation to relieve him for that, because if the muscles of the lungs start doing that, he's going to have respiratory distress. So that's a very sad picture of a typical, you must have seen, I don't know whether you did or not, but if you rotate in psychiatry ward or some of the neurology ward, you'll see a typical picture of some of the other problems that we normally come across in terms of contractions of the muscles, but epilepsy, for example. So that kind of may mimic a little bit, but this infection is severe. It is very severe. So what do? We basically look at the picture. Of course, if you look at this picture, you cannot forget it. So you know the clinical presentation is the major thing. You know the person has tetanus, and you always have a history of a cut, a wound, a roadside accident, or something of that nature. Of course, you need to do microscopy, and you want to make sure to look for a serology, but unfortunately, you can see from here, most of the time we are unable to detect antibodies. So that's why your immune system, that's why we have this vaccination. So we have this tetanus toxide. And as the name suggests to you, this is a toxide. So you are given antibodies for that toxin that would have caused that picture. So you can see the importance. And sometime I remember one of the students came to me and he said that, I don't believe in a vaccination of my kids. And, so it's tough for me to say that. But again, it's very severe. I would rather have at least your babies and kids take vaccine, because those poor fellows cannot have the authority to make choices. You're making choices for them, and that's maybe a difficult situation that you may have being misled by the conspiracy theory of the use of vaccine and so on and so forth. But still, I would argue that people should avail themselves or have their loved one take complete course of at least pediatric or childhood vaccination. All right, if you see a wound, you have to completely get rid of the dead tissue. That's what's called debridement. Antibiotic of choice is metronidazole. Once we see that happening, of course, we can give passive immunization. Again, if you know passive immunization is basically we give you the antibody, the prepared antibody, as compared to active, where we will give you a toxin and let your immune system see this is the poison, but this poison would not cause disease, and you educate your immune system and they make antibodies to that, and those antibodies can stay in your system for a longer period of time. Yeah. Disease itself. If a person has had a disease, like say, oh, I had this disease when I was a baby, doesn't mean that he doesn't need a vaccination. There's no lifelong immunity. This is something that we prepare. So we prepare those specific antibodies and then again give it to that particular person as a vaccination. But again, the question will be, we are doing a short-term treatment because you don't want that kind of a clinical picture to happen, right? So we have to make sure the toxin, while it's released, is being removed from the system. You don't expect it to stay for a longer time in the body. So this is the prevention. You have to have 3 doses of tetanus toxoid followed by booster doses of 10 years. So you can see and you can basically educate yourself and the patients. This is serious. We better get this toxin toxoid every 10 years. Clostridium botulism. Botulinum causes botulism. Again, there are many strains for that, type A, B, E, and F. And again, it has a toxin, which basically have 7 distinct toxins. And you wonder, why do we need to know that? Because remember, we have to deal with these toxins in terms of preparation of antibodies, number 1, in terms of coming up with the drugs. So you can see from here, compare this one with the tetanospasm. That's usually, I'm very fond of asking this question, so I'm going to spend some time on that. This particular toxin, this prevents the release of neurotransmitter acetylcholine, as compared to the previous one, which blocked the inhibitory neurotransmitter like GABA and glycine. So what will happen is that the first case, you have contraction. In this case, you have relaxation, paralysis. We call flaccid paralysis. You like think dangling down loose. Both are bad, but the other one would cause that picture, and this one again will cause respiratory distress, because remember, for a good normal muscle activity, you need contraction and relaxation, whether it be heart, whether it be for any movements. You have both. If you have one and not the other, the function will be lost. So if you have contraction with no relaxation, right, so you cannot breathe in. If you have relaxation with no contraction, you can breathe in and you cannot breathe out. So equally bad. So both are bad, but of course the treatment is different, because the other one had, blockage of inhibitory neurotransmitter, and this one is blocking acetylcholine. And remember, I told you the other day that bad for bacteria, bad for us, for good for people who want to make money for Botox. So if your facial muscle gets contracted, they give a very titrated small dose of it, and your muscle kind of tend to relax, and you feel that you look young. That's what it is. So epidemiology, these are again spores present everywhere. In United States, basically, we do see cases, very few of them, but they are very high in developing countries. As I said earlier, infant botulism, if you remember me talking about that, next time you buy a jar of honey, you will see it will say tested for Clostridium botulinum. Many times they have to make sure that the honey that comes in the market is spore-free. And then a word of caution for those who want to go for picking up stuff from the farm, they may not have tested it for Clostridia, and so we have to be careful. You can take chances on yourself, but I would not feed that to an infant. Okay. Now, again, the picture in this one is foodborne botulism, infant botulism, wound botulism, and inhalation botulism. So you can see that depending upon where the injury is, the toxin is released. If it goes into air, it's released over there. So the basic pathophysiology is that this particular bacteria releases those sets of toxin. If it happens to be neurotoxin, they will compromise the function of the neurons in that area. And you can see, especially the whole picture for all these 3-4 things is, they all cause flaccid paralysis, flaccid paralysis, flaccid paralysis. So they basically go and operate on another way as compared to the contracture, right? But again, remember, so you need to find out which is the culprit. Remember, you see a person in respiratory distress, and you think it could be Clostridium tetani or Clostridium botulinum. So there are two different treatment modules. You have to make sure they use the right one, otherwise you're going to aggravate the conditions that person may go through. For diagnosis, again, we are looking for the toxin, and this toxin has been shown, of course, in patient serum, in feces, and in gastric fluids, and especially when we look at a case in neonates or infants, we detect them in infants' feces, and then basically culture the feces and look at the antibiotic susceptibility. And then again, if it happens to be a wound confirmed with that, we need to take a wound swab or look for that particular toxin in patient's serum, and then we make our diagnosis based upon that. Okay, does that make sense? So it depends which particular part of the body is infected. And again, if you see a foodborne, as I said, honey, so you have, body has this homeostatic mechanism. The moment it sees a toxin, it gets irritated. It wants to flush it out. So diarrhea, dysentery, all these kind of things are something protective. They want to get rid and flush out everything. But then again, you don't want to flush out all your water and salts. So we need to do something for that particular problem that the patient may have. And many a time it's also self-limiting as well, depending upon how much toxin have you consumed. If it's mild, you see like a mild gastroenteritis, and you can make do with that. And also depends upon the age as well. Of course, infants basically have less reserve for water, so we need to make sure that they don't lose water, they don't lose salt, and they're not going to tell you what's going on. So we have to be very careful when we deal with them. Okay? Okay, now treatment, prevention, and control. Again, metronidazole or penicillin. We have a trivalent botulinum antitoxin and ventilatory support. That makes sense. That is an issue over here. As I said earlier, many food products usually classically are being made in acid pH, high sugar content, and we want to make sure they're stored in food. But you may break that chain, the cold chain. Remember, as I said the other day, because the burger you're getting or a sandwich you're getting is coming from Florida, and then there's a breakdown of the AC system on the way, and nobody knows, and then so you may have that problem that the spores can germinate, but many times they will trace it back, strain typing, and they will definitely look for it. Okay, another important thing that I want you to keep in mind is that the toxin for this particular bacteria is a heat labile, so it's good for you if you can heat it up for 10 minutes at higher temperature, so toxin will get rid of it. But of course, you cannot heat your burger. So liquids are okay. So that's another way of heating it up. Infant botulism, I said ingestion of contaminated soil or consumption of contaminated food, particularly honey. So that's what I already told you, that it is a FDA policy, and you will see that seal almost all industrial use of honey. And the last bacteria for today, again, is something that we may have discussed earlier as well. And on a recap again, Clostridium difficile. And again, most of the strain in this particular family, they produce two toxins. One is enterotoxin, that basically attracts neutrophil and stimulate the release of cytokines, and cytotoxin. So these are basically, you can see from here, more to do with enterotoxin. And remember, some of the bacteria like viruses have a term we call tropism. Tropism means they have a liking for one particular set of epithelial tissue, like flu. So the flu virus will want to go in your nose because that likes to stay in your nose. Some of the viruses are rotaviruses. They want to go and sit on your intestine. Some of the viruses, like herpes virus, want to go after your skin. Some of the viruses want to go on mucosa. So this is a property of those particular microbes to have that liking, we call affinity. The term is tropism. So in this case, Dafficil has a tropism attraction for your enterocytes, your intestinal cells, because it secretes enterotoxin. So when it secretes enterotoxin, so you can see, what do you make of this, that this particular enterotoxin is going to attract neutrophils? So what do you think is going to happen if this particular toxin, because neutrophils are good phagocytes, they can take in bacteria, right? But what do you think, why are they calling in neutrophils? And it is an advantage for the bacteria or advantage to us? It's an advantage for bacteria, of course. Bacteria is not going to be, loyal to you. It's going for own. So what do you think is happening here? What will happen if I ask you that this enterotoxin is going to invite neutrophils and invite cells that produce quite a few cytokines? Sorry? So what would that do? Well, as a rule, the answer is already there in the slide, because there are cytotoxins. Because the thing is that uncontrolled inflammation. So they will ask these neutrophils to come over and cause damage to your own cells. So they will invite these cells and cause local damage. So you can see from here, there are also spore formers. And again, what will happen is that this cytotoxin will increase the permeability of intestinal wall. So you will lose, because remember, one of the most important function for enterocytes, intestinal cells, is that they are a barrier. They hold your water and salt. That is one of the prime function of enterocyte. So there's a barrier there. If it breaks, then again you will have colitis and diarrhea. And then again, as I said earlier, antibiotic resistance. These particular bacteria are resistant to certain antibiotics like clindamycin, cephalosporin, and fluoroquinolone. So these are important because these bacteria are having antibiotic resistance. And then again is a very common question asked. So what will happen is that you normally want to control diarrhea by giving antibiotics. And sometimes antibiotics themselves will cause diarrhea. So what do you do then? You have to stop giving antibiotics. Then again, if you stop giving antibiotics, then bacteria will thrive. So this is like, that kind of very sharp balance you have to keep. But the idea is that one should avoid overzealous and inadvertent use of antibiotics, especially when you are dealing with Clostridium difficile. So, so antibiotic-associated diarrhea, that's pretty much the most important clinical picture of Clostridium difficile, and that is not with any other bacteria that I've discussed so far. It is an acute diarrhea developed 5 to 10 days after initiation of antibiotic treatment, especially if you put your patient on this one, right? And then again, what will happen is good bacteria, you want to go for nasty bacteria, they will be killed as well. But in the process of you killing your foes, you will kill your friends as well. And there is a disbalance between good and bad, and Clostridium difficile will overgrow. So they are good, they are your friends if they are in that kind of normal number, but if you give them a chance to overgrow, then they basically cause a problem. So they develop a disease which is called pseudomembranous colitis, which is a very severe form of C. difficile disease where you have profuse diarrhea, abdominal cramping, fever, and vitus plaques on your colonic tissue. So you may want to, if you do a colonoscopy on this patient, this is what you get. So you can see a typical picture of a vitus plaque of fibrin, and you can see all those kind of mucus over there, and then they are inflammatory cells overlying the normal intestinal mucosa. So that's what enterotoxin does. It's going to call in cytokine, call in neutrophils, which are good, but then again, they're out of control, and then they cause local damage. You have a very severe form of diarrhea. You don't know what to do. It is initiated by antibiotic therapy for those 5-6 antibiotics that you're using. So you have to look at the gross section of the colon of those people, colonoscopy, and you see a typical picture. This is called pseudomembranous colitis. It is not a real membrane. It's a pseudomembrane, but there is inflammation of colon. If you look at the histological section, you can see intense inflammatory response. And you can see over here a plaque. This is a plaque. Over here a black arrow, which overlies the normal intestinal epithelium. And then again, the whole system is messed up. As I said earlier, Clostridium difficile basically colonizes less than 5% of healthy individuals. So it's not like a normal. So many times, I may have said earlier, but you just have to keep a note that Clostridium difficile, basically of all the different types of Clostridia, are not normal colonizers of your intestine. Only a small percentage of people, this is 5%. So when you give antibiotic, you basically give them a chance to overgrow. That's basically the principal mechanism of pathogenesis. And then again, you have to be very careful in hospitals because spores can be detected. And then again, a highly virulent strain of C. difficile has been shown, especially in this country. And so you can imagine that highly virulent means that all your antibiotics fail. So that will be a very drastic thing, that you will come up with a strain that is caused by use of overzealous use or inadvertent use of antibiotics. You want to give a broad spectrum antibiotic. You want to give tons of antibiotic for one purpose, and you are going to have C. difficile overgrowth in the system, and then it's going to cause more problems. How do you diagnose that? Of course, you can confirm by looking at those enterotoxin in patient's feces. How do you treat it? Number one thing is that you have to discontinue the antibiotics that initiated it. And then again, you have to use metronidazole or vancomycin. Relapse is very common, and you have to make sure that your hospitals and your clinics don't basically have that kind of ability to grow these spores. So that remains as a major challenge for you to take in control. Okay, and as I said earlier, I did see in Murray's book there are a lot of comparisons I would want you to do on your own. So all those 4 different types of Clostridia that I've talked about, they may look similar, but definitely they have different toxins, they have different clinical picture, they have a different neurotransmitter blockage, and they have a very different tissue damage. So I would make a chart, and I do see that your chart over here, which I found very good. You see Clostridium diseases, Clostridium perfringens, disease it causes, Clostridium tetani, disease causes, Clostridium botulism, disease it causes, and Clostridium difficile. So what I would do is that this kind of a chart will be good for pathogenesis as well. This kind of chart will be good for epidemiology as well. And then again, I would definitely encourage you to start with the basis so you can differentiate. And again, the whole idea is that you don't want to give a broad spectrum antibiotic, especially in the case when you get tissue damage because of Clostridia. Okay? So what I would do is that, as I said earlier, make a chart and have at least pathogenesis between all 4, have the toxin produced by the all 4, clinical picture, this one is good enough, and then also control mechanism, and then finally make sure that you know the use of antibiotic or vaccine. I may have